All right, let's just get started now. It's 6:15. For those of you who don't know me, which is almost none of you, I'm Ryan Lee. I'm the head and neck fellow this year. I'm doing a combined ablative and microvascular reconstruction fellowship. Thank you for joining us today. So I'm going to be talking about managing osteoradionecrosis just in a contemporary setting, particularly of the mandible, because that's where we really see it. I don't have anything to disclose. So the three things I'm going to touch on today. One is just a brief overview of the pathophysiology of osteoradionecrosis as we know it nowadays, and then discuss what the contemporary management of it is, which is sort of still in flux, but I'll go through some of the literature that substantiates the way we handle these patients. And then lastly, this is sort of a pet project of mine that I had during residency was a surgical quality care improvement, and I'll just go through a couple of studies that we did at the end of my residency. So a basic background for ORN, it's considered more of a late complication of radiation therapy, either in the radiation therapy that's been given as primary treatment or in the adjuvant setting for head and neck cancers. And the traditional rule is that symptoms, which I'll go through next, had to be persisting for at least 3 to 6 months. And so signs that you would see for a patient that had ORN included bony exposure intraorally or externally, and pathologic erosion or fistulization to the skin, so orcutaneous fistulas. And then pathologic fractures, of course, is another one. And then the symptoms, which some overlap with just long-term adverse effects of radiation therapy itself, would include trismus, and neuropathic pain, and chronic drainage, either intraorally or externally. So I actually found this recently. This is an article out of Hong Kong University that was looking through a systematic review of ORN cases in the literature and just trying to study what the incidence change has been over time. So it's a little bit hard to read this, I apologize, but this is, on the y-axis, this is just percent of patients undergoing radiation therapy of some sort in individual studies, describing what percent of them developed ORN. And in 1968, you kind of see this dramatic drop from near at 40% incidence of ORN down to 14%, and then in the present time down to 2%. And part of the speculation why this happened, it's more than just speculation, was that the way that radiation therapy was administered changed dramatically over the span of 1966 to about 1970. So they started to use linear accelerators. This is all, the physics is all above my head, but started to use linear accelerators rather than what's called ortho accelerators. And what that does is that allowed them to modify and then contour the beams much more effectively and accurately to avoid vital structures like the mandible if it wasn't involved. And then another major change during this time period was the implementation of strict dental protocols for preventive care for patients who are receiving radiation therapy for head and neck. So just the spectrum of ORN in a nutshell, it's important to just think about it in sort of the least and most severe forms so you can understand it better. A mild form, and this is kind of this is sort of taken out of Dr. Marks's protocols, and Dr. Marks I'll talk more about later, is sort of the father of the movement to use HBO and manage ORN that way conservatively. So mild ORN consists of generally of a lot of inflammatory changes to the mucosa overlying bone typically without any major bone exposure. So some papers talk about less than a centimeter of bony exposure. And there may be very focal bony resorption radiologically. In moderate ORN, these findings, these signs and symptoms are just a little bit more advanced. And then classically severe ORN has been described as happening in patients that have pathologic fractures, through and through fractures of the mandible, and development of orcutaneous fistulas. So this is just a selection of some of the patients that we have taken care of here at Stanford, as well as this one's actually out of this paper. But what you can see in these two cases are orcutaneous fistulas. They're somewhat crusted over, but they were chronically draining. This is the same. This is this patient here. And he's already been plated intraoperatively, but you can see this is a pathologic fracture. We didn't create this fracture here. And then this lady this patient had a plating previously that is now completely exposed with necrotic non-viable bone. So what's the pathogenesis of ORN? We're not going to go into basic science, but the general principle is that radiation induces a type of endarteritis that destroys microvasculature and some macrovasculature within the mandible, if we're just focusing on the mandible. And that leads to hypoxia, as you can imagine, and anoxia to tissues and hypovascularities. It's just ischemic changes that persist chronically. They don't get better in time for many patients, at least locally. There's this theory that osteoclastic activity is also reduced dramatically in these patients, and that leads to poor physiologic bone turnover. Because you can imagine, bony metabolism is not just osteoblastic bone growth or bone buildup, right? It's also the turnover of old bone. And then, in addition to that, there's this concept of ORN necessitating the need for a traumatic event to have occurred. Okay? So dental extraction is the classic example. And not all ORN cases are preceded by some traumatic event, which we'll talk about in a moment. Infection is the norm. It may not necessarily be the inciting factor that causes ORN, but it's sort of concomitantly present in almost all cases. Okay, so early onset ORN versus late onset ORN. Early onset spontaneous quote-unquote ORN usually occurs about less than 2 years after radiation therapy is completed. And that doesn't necessarily happen in the setting of a trauma, of a dental extraction of some sort. We talk more about dental extraction precipitating ORN in chronic cases, greater than 2 years out, although they can happen at any time. But the point here is that patients who have been radiated to their mandible to a significant degree, they are at risk for ORN for the rest of their life, just definitely. Okay, so you always have to be thinking about, especially in terms of dental hygiene and whether a patient necessitates a dental extraction down the road, whether this is worthwhile for a patient who's been heavily irradiated to their mandible. So most episodes or most instances of ORN occur within 2 to 5 years of radiation therapy. So what does it do to patients in terms of quality of life? Mark Erkin at Israel, New York, talks a lot about this, the loss of enjoyment of just these oral pleasures. Eating, chronic pain is a common thing that we've seen here. We've seen about 15 cases of ORN since July, and pain is a common problem in these patients. Let alone just psychologically, there's frequently an unclear endpoint for treatment. These patients, their treatment just drags on and on. You use supportive care for years at a time. I'll go through a couple examples, a couple case studies in a bit. So all of this is compounded by the side effects of radiation therapy itself, right? And they're sort of mangled together, the symptoms and side effects, whether they're associated with ORN or with just radiation changes. So xerostomia leads to dental caries, leads to necessity to perform dental extractions, and then that can precipitate ORN. And then a smattering of other really miserable symptoms, trismus, dysphagia. It's just very socially and emotionally debilitating for these patients. And just to show that a little bit more, in this study, this PSS scale it's an inventory that's administered to patients, and it's a list of basic questions that they ask patients about the normalcy of their diet, the consistency of it, and whether they're comfortable eating in public. And this is a comparison study actually between patients who had, I mean the numbers are small, but had ORN and patients who were treated for head and neck cancer but that didn't have ORN. So it's not a comparison between ORN and normal patients, or normal people who have never received any radiation therapy or never had head and neck cancer. But there's just dramatically worse quality of life by this metric in patients with ORN, even compared to their head and neck patriots who do not have ORN. So what are the goals of care when we treat these patients? One is clearly to improve their oral diet. A lot of these patients come in either PEG tube dependent or at least partially G-tube dependent. Restoration of dentition, it's a secondary goal, but it is something that we talk about, and it's something that I'm learning more about this year. Fortunately, we collaborate a lot with Stanley Liu now to try to see how we can sort of do a one-stop shop in restoring dentition as best as possible. And that's obviously entitled, but overall quality of life is important, right? Your oral quality of life is very much tied into how you live your life and how happy you are on a daily basis. This is a table from an article from MD Anderson, and they see a lot of of patients with long-term late radiation toxicity. And this is actually thanks to Dr. Wendy Hara from radiation oncology. She showed me this. What you'll see on the y-axis here is the percent volume of the mandible that was exposed to a certain dosage of radiation therapy. And then on the x-axis, so V10, V20, these numbers basically mean the grade, the dosage of radiation therapy that was administered. So for example, V50 means what volume of the mandible received 50 gray of radiation therapy. In this case, in patients, in a set of cohort of patients with ORN 40%, versus in the cohort of patients without ORN with head and neck cancer 30%. The take-home message here is around a dosage of 50 gray and 60 gray to the mandible. It's not only the fact that that's a high dosage of radiation that matters in terms of increased risk of ORN. It's actually the volume of the mandible that is exposed to that dose that matters as well. So this is also courtesy of Dr. Hara. This is part of one of her planning sessions for a patient who had a tonsillar primary. And we're now in the era of intensity modulated radiation therapy where they can really contour it. It's remarkable how well they can contour the radiation beams to the primary site. And if they anticipate that tumor does not involve or abut the mandible, they can dramatically decrease the dose that's administered to the mandible. So the lighter the colors here, the lighter the exposure to radiation along the mandible. And in addition to this, just on a side note, they can very effectively spare salivary glands, which will lead to less xerostomia and ultimately theoretically lead to less risk of ORN. Wow. So this is unfortunately a very important slide. So preventive care is critical for these patients, right? You want to anticipate as much as you can what types of sequelae they're going to have from radiation therapy before they even begin their treatment. So dental care, dental consultation with a dental oncologist, preferably, is paramount. For patients who are undergoing radiation therapy, it's critical to anticipate whether any teeth need to be extracted prior to the start of the radiation therapy. We prefer to do it at least 3 weeks prior to the onset of their radiation therapy. And not closer to that date. Weekly checkups during RT to make sure patients are taking their fluoride trays on a daily basis. So the follow-ups are not just to look for signs and symptoms of ORN or signs and symptoms of radiation toxicity during their treatment. It's also just to see that they're compliant with their dental hygiene. And I think that's a critical part of what we do, or what the dentist can do as well. After radiation therapy is completed, you can see the recommended follow-up is very close, 4 months, and that's kind of indefinite since they continue to be at risk for ORN for a long time. This is a classic protocol called the Marks protocol. Dr. Marks is an oral maxillofacial surgeon. He's now at University of Miami. And he put together a sort of a spectrum of severity of ORN stage 1, 2, and 3 that basically was predicated upon how well patients respond to hyperbaric oxygen therapy. So in a nutshell, what this is saying is that the administration of hyperbaric oxygen theoretically increases the oxygen tension in bone, and bone that's been radiated needs more oxygenation. It's supposed to be antimicrobial. It's supposed to lead to better wound healing in the bone, and that was the theory behind the administration of HBO for these patients. Okay. The poorer the response of the patient to HBO, the higher the stage of severity of ORN that is diagnosed by Mark. So it's kind of a treatment response dictates how severe their ORN is. There comes a point where HBO no longer becomes a consideration for these patients. That's stage 3, where, as I alluded to previously, usually entails a pathologic fracture or a cutaneous fistula that just won't close. So this is actually the only randomized controlled double-blind study that I could find for administration of HBO in patients with ORN. And this was done about, I think it was 2004, 2005. And it's a study that had 2 arms. One was just patients allocated to receiving HBO, about 31 patients, and then 37 patients allocated to placebo, which included the normal supportive care, so very mild debridements of exposed bone or diseased mucosal tissue, and antibiotic therapy as indicated. Okay. This is a pretty important study, I think, because there are countless. There are about 50 to 60 case series in the literature that have 50 or 60 odd patients within them that are not true comparative studies to show what's the efficacy of HBO. And the bottom line is, this is statistically this is far above my head, but this is called a triangulated analysis, and it's basically a way to assess patients as an interim analysis to see whether they are benefiting from the therapeutic arm of the trial or whether the trial should be stopped. And the bottom line is, very quickly in this study, you see this red dot here, it falls within this blue triangle, which means ultimately that the patients in the group receiving HBO started to fare worse than the patients who did not receive HBO. And by 1 year follow-up, 19% of patients that received HBO had recovered fully from their ORN, whereas 32% in the placebo arm had. So the bottom line is it just showed that it clearly had no superiority to administer HBO over what was called placebo in this group. And ultimately, also another important point, their endpoints were pain resolution, full coverage of bone intraorally as well as externally, and no progression radiologically to severe ORN. But 85% of patients ultimately went on in both groups to recover fully from their ORN, to resolve fully. But that's over the span of 2 to 5 years. That's a long time for these patients to endure this kind of suffering. Okay, so as I said before, we've had 15 cases so far of severe ORN here, managed in various ways since I joined the service in July, and they've been treated in various methods. All patients have required segmental resection of the diseased bone, but the reconstructive aspect of this is very based on numerous factors, which I'll go on to in the subsequent slides. Not all of them received bone reconstruction of bone.
So back to the previous trial, why didn't it seems that people are still getting a lot of HBO for ORN.
So the subtlety of this is that it's again all these studies, including this one, had very heterogeneous populations. So the spectrum of severity of ORN was very different, actually, even within groups and between these two groups. So it's not really clear. There's probably a select group of patients that probably do benefit from HBO. It's just not a panacea, and it generally is understood to be more effective for patients with mild ORN, and certainly not a significant player in helping patients with severe ORN. So the more severe the ORN, the less beneficial it is.
And how costly is HBO? Like, how long are the dives? Like, how much is it time invested for the patient?
I mean, you did a lot of HBO, right, at the Mount Sinai here?
Yeah, we did I don't know about the billing side of it. Yeah. I want to say it's like $300 a dive. 30 dives.
They do 30 dives.
Usually for pulling teeth, it's 20 before, 10 after. It's ultimately one of those things where all the meta-analyses that have actually come out basically don't show much of a difference. Mm-hmm. A lot of the research that is pro is not really well run. And that's true for a lot of HBO stuff. You actually look at it, they sort of undertreat one arm and findings are vague. But I think most people go on and it's even if there's a small chance it might help, it's a low risk intervention. And I think the standard of evidence in general in medicine, when there's low risk interventions, it's pretty low, and so we still do it. And I think it's unfortunately one of those things too. If someone had ORN to get recommended it, I think it's like a medical, people that's their fear is that someone's going to sue them.
And then how long does each dive last?
I think it's like an hour and a half.
Sure. With as many dives.
So that's like a big time commitment.
Yeah. It's like radiation almost.
Yeah.
Okay, so before we talk about some of our cases, I found two of the larger case series in the literature from very experienced institutions. This is one using free flaps to reconstruct patients who have been treated with segmental mandibulectomy for ORN. This is a collaboration between Dr. Rosenthal and Dr. Wax's groups at University of Alabama and OHSU in Portland. And part of their study was just reviewing the literature, doing a systematic review of various studies that have utilized free flaps to treat patients with ORN. And you can see the complication rates are high. They're very high. And the complications include infection, fistula, higher than here, and refracture and breaking of the plating systems. But also, take it for what it's worth, the vast majority of patients recover fully from their ORN over time. It just becomes a long, drawn-out process that can literally take years, many months, if not years. So that's the study from UAB and OHSU saying that. And this is another study of a large case series, so 63 patients over 10 years who were treated with reflaps for treatment of ORN. So this is from MD Anderson. This was published a couple of years ago, and it basically showed a couple of things. Bone flaps tended to result in more complications than soft tissue flaps, which is a little more technically difficult, the insetting, the placement of the skin panel. Skin panel may be a little more tenuous. And all in all, what I wanted to get out of this paper was that the rate of patients resulting in a full oral diet, so no dependency whatsoever on either NG tube or gastrostomy tube, was 57%. So not great. Partially good. Partial tube feed dependency was 27%, so overall, over 80% of patients had at least resumption of some oral diet. There's a significant amount that still require a G-tube for their complete nutritional requirements.
That's one of our former residents, Matt Hanasan.
Yeah, Dr. Hanasan. Yeah, great guy.
He's a good guy.
He's a great guy. So, I mean, these guys are heavily experienced with this. It's remarkable that we've seen 15 cases of ORN since I've been here in July, when they saw 63 over 10 years.
We're doing something wrong.
Yeah, they're coming. Yeah, one second. Right. So, this is another study from Dr. Hanasano as well, actually, at MD Anderson, and it's just debating the concept of how do you reconstruct the mandible, when do you need soft tissue versus when you should replace it with bone, right? We talk a lot about how the condyle is addressed. If the condyle is diseased in ORN and has to be removed, can you effectively reconstruct that with fibula or any other kind of osseous flap? It's very challenging to do because it's not so much just contouring a joint, contouring the joint and placing it in the glenoid fossa. It's more so all the ligamentous attachments that you just can't recapitulate in reconstruction of the TMJ. So he compared reconstruction of mandibles that had a mixture of condylar loss, condylar head loss, and matched them between two groups. So a group that received an osseous flap and a group that received just soft tissue reconstruction. So 24 patients versus 50 patients. And so the major difference between the two was the amount of crossbite, which kind of makes sense. So patients who receive only a soft tissue flap reconstruction, so they're swinging, their mandible is swinging, had markedly increased crossbite. And that makes sense because the pterygoid musculature on the contralateral side to the disease side is pulling everything medially, and if you don't have that structural support on the side that you're reconstructing by placing bone in, it's going to deviate more. They didn't reach statistical significance in terms of differences in mouth opening, so the ever-lasting problem of trismus in these patients, the painful problem of trismus. So, but they did show that trismus was potentially decreased in the patients who received soft tissue flap only, and that can also make sense too, right? Because replacing bone with bone and plating the bone to whatever remnant condyle there is can still restrict the motion of mouth opening a lot. It leads probably to a lot of fibrosis as well of the remnant condylar head. Okay, so the spectrum of ORN that I want to talk about, I'm just going to present one mild case and one severe case that we have encountered here. These photos are courtesy of Stanley Liu as well. So this is one patient. Both patients were treated for a tonsillar primary squamous cell carcinomas with radiation therapy. And this is an indolent case. This patient had a lot of oral pain that began about 18 months after her radiation therapy was completed. Okay. Let's just see on the front view. If you look at her Panorex film, these are Stanley's films actually, you can see the sclerotic change, this superlucency in the right body mandible. This is, these are 1 month apart, so this is 1 month later, just more sclerotic change. This is rapidly progressive actually for this patient. And miserable, right? The only thing she has left is the inferior cortex to keep her mandible in continuity. She doesn't chew her diet, she was G-tube dependent at this point. So intraoperatively, so plain question is basically, what do you do with this? Okay, intraorally she had this basically before we debrided her. So this patient had what's called a sequestrum, which is essentially necrotic bone and necrotic mucosal tissue intraorally. And because her mandible was still in continuity, and she had a fair bit of inferior cortex, and we did not want to fracture her mandible, did a conservative sequestrectomy down to bleeding mandible. And there was bleeding mandible underneath this necrotic bone here. And rotated in some mucosal flaps to cover this. Okay, in this case, this actually worked out fairly well. Okay, and, time will tell whether this is going to be her last surgical treatment or if she's going to progress to more severe ORN.
Still G-tube dependent? I mean, could she
She's
use
taking
that
some
shot?
PO. She's taking some PO. I think the main point is that this was not a quick fix. She still requires enteral feeds through her G-tube to maintain her calories, but she's at least able to take some. With this, on the right, it did look exactly like this in the clinic, but somewhat like this, there's no way that a patient is going to be able to appreciably eat anything. All right, so onwards to a case of severe ORN. This patient presented 7 years after radiation therapy was completed for a tonsillar primary cancer. She has trismus. She has a lot of pain as well intraorally on the left side. And if you look at her neck, there's no fistula per se. That impressive. And this is on her initial visit. She had a little bit of purulent drainage, not very that well illustrated here. Just a little bit of purulent drainage behind her molar on the left side. Pretty subtle, no bone exposure. Panorex film shows marked lucency of the body and the angle and the ramus of the mandible on this side. It's all preoperative. The CT scan shows disruption of the outer cortex of the mandible and the inner cortex as well. One of the things I forgot to add was, what Dr. Marks did not have the benefit of having back in even the early 1980s was high resolution CT, just the radiologic diagnostic studies that we have available to us today. It's much easier for us to assess this beyond physical exam. This is just a 3D reconstruction from her CT scan, just to show the rat-eaten bone of her left body and angle of the mandible. Yeah, right. Probably would have eventually. So we've been using this Synthes program a lot, and it's been very effective and helped us a lot with our efficiency as well. And so basically you can submit, a lot of you know this already, you can submit a high-resolution CT scan to Synthes, and they will do a model planning for you so that by the time surgery rolls around, you can have a pre-fashioned custom-made plate for these patients, titanium plate, and a custom-made model as well, which I'll show you. But this was sort of the plan for resection for her. What I didn't show was her MRI for this patient, which also is helpful in showing the marrow changes within the mandible and helping to determine the extent of resection that is going to be required. This is just a model sort of depicting how we thought the mandible would fit in, or sorry, the fibula, which was the plan for this patient, would fit into our reconstruction. This I have not seen yet before, but this is a guide for placement of dental implants at the time of this surgery. So, as I said before, that one-stop shop is a great concept where you can reconstruct the structural integrity of the mandible as well as place the bony implants at the same time. So them a second surgery. This is one of the models. That's actually this is a model for this patient, and this is the Prevent plate. It's actually a plate that's pre-milled, so it's I don't know all the subtleties of it, all the details of it, but as opposed to a plate that is bent out of just a standard plate, this has been milled out of. Also, you can speak more to this out of I believe solid titanium block. So it should have more structural integrity than a plate that has been bent back and forth multiple times and been weakened by them. These are intraoperative photos. You can see the disruption of the outer cortex of the mandible here. And this is all the bone that actually was resected in the end. So it was resected in multiple segments because there are areas where bleeding tissue was not identified until we took an additional segment. And this part, I wasn't involved with this part, but this is where Stanley was actually placing the dental implants using the drill guide that was fashioned by Synthes. The plate has been placed to connect the remnant mandible, and the fibula is going to be inset. There it is. This is her post-operatively. Critical things to focus on intraoperatively are whether the occlusion is maintained, is preserved, right? And so before, after, a very successful maintenance of her occlusion. And she looks good, right? A little more swelling, but overall, reasonable cosmetic result. This is post-operatively some of the dental implants, the posts that are in place. You can see how the height difference here when these are placed in fibula, right? Because the fibula obviously is not the full thickness of the mandible. And it's a little bit of a challenge to get through the soft tissue. See if I have a picture here. This is the skin paddle intraorally. The implants are going to go partially through the skin paddle into the post here, the long reach.
I thought that
Yeah.
gingiva has magical properties to allow something hard to go through into a saliva, bacteria-rich saliva.
Amazing.
Can you do it through a skin graft? Or through a
skin
flap, I should say. It's not gingiva,
Yeah, yeah.
but skin works and adheres to an implant?
It does. It does. So I mean, it will integrate. So the post will integrate to the bone, and
Yeah.
like when you do Bajas, right?
Yeah.
You kind of have to free the skin around it in order for the implant to really integrate. But yeah, it works. Yeah.
But I
by
don't
that
spit on my Bajas.
Put a free flap in your Baja. Okay. So again, I think we found this to be very effective to use the 3D planning model. It's very educational too to try to plan beforehand what you think your osteotomies are going to be before going into surgery, and then to see what it actually is at the time. When a patient already has a pathologic fracture, for example, in this case, there's just a wisp of bone here. Their occlusion is all off. The symmetry of their mandible is completely distorted preoperatively, right? So one of the benefits of Synthes modeling or any other company's 3D modeling is that you can make a mirror image of the contralateral hemimandible. That can help you to get an idea of how to restore symmetry to a patient who already has distorted symmetry preoperatively. Okay, so quick segue. This is just my quick push or quick support of quality improvement in surgical care. We see we're challenged by a lot of serious complications, particularly in head and neck surgery, but all of our subspecialties as well. We're stuck with patients who have been radiated, their tissue is not healthy, they suffer many wound complications, and we want to do our best to not only treat their cancer, obviously, but to have them have a good quality of life after they finish their treatment. So, just very briefly, when I was finishing my residency, we had started a sort of checklist manifesto, sort of checklist protocol of very simple perioperative measures that we could use to improve surgical outcomes in patients. Hypothesize would improve these. So I'll jump through these pretty quickly. Which patients are at risk for pharyngocutaneous fistula? We all know, patients who have had a pharyngectomy as part of their laryngectomy. Theoretically, patients who have had robotic surgery with neck dissections, there's a theoretical risk of creating a communication between the neck and the oral cavity, but it's a low risk. And then patients who have had composite oral cavity resections, which require defect reconstructions. What are some of the risk factors that we could address for these patients? Prior radiation therapy, obviously unavoidable, but to be cognizant of it. Diabetes, we had a patient earlier this year that we did a floor of mouth and hemiglossectomy resection and then radioform free flap reconstruction. And she had a wound infection post-operatively. And we knew beforehand, we didn't have a choice for her because this is cancer surgery, you can't wait too long, but her HbA1c before surgery was 15. And we got it down to 10 before we went into surgery, but it's still, a really unacceptable metric of diabetes control. Nothing you can do when it's a patient who needs cancer surgery, right? Except just be vigilant at the time, the perioperative setting. Hypothyroidism. So Dr. Rosenthal is a senior author on this paper that describes the risk of wound complications and fistulization as significantly increased in patients who are hypothyroid. So big champion of always checking whether patients are euthyroid in the perioperative setting. And then there's a lot of basic sterility and antibiosis measures that aren't always strictly adhered to around the time of surgery, and it behooves us to be vigilant about these. The take-home message from this slide, though, is that the risk of complications in patients who have head and neck surgery is a combination of many different risk factors. It's a multifactorial problem. A single silver bullet is going to fix all of these problems. So for the year 2013, at one of our satellite hospitals, not the main Hopkins hospital, we had several head and neck surgeons put together a checklist to address the risk factors that were on the previous slide and try to see whether this improved their surgical outcomes. We're particularly interested in oricutaneous fistulas. And kind of the impetus for this, to be honest with you, was that we started to experience a significant rise in the rate of oricutaneous fistulas. And it was hard to explain. It wasn't perceived as something that was a technical snafu by our surgeons, by any one surgeon in particular. So just jumping through this, this is the checklist that we use to address these risk factors for these patients. As we do here, dental referral, we did religiously. Part of this was just the fact that we had a checklist that we had to check off for every single patient that underwent head and neck surgery, not just major resections. And in this checklist, endocrine consultation was mandatory for all diabetic patients preoperatively. So it was not enough to just shoot for good glycemic control during their inpatient stay. It's best to try to optimize them as much as possible in the preoperative setting. TSH for all patients who had previously received radiation therapy was also just a simple measure. And then all patients received a sterile scrub. Actually, they received instructions to do a sterile scrub at home. And most of them endorsed being compliant with this. This CHG is just chlorhexidine. They also got another wipe with chlorhexidine in the preoperative area. To be honest with you, this is not a strongly data-driven measure, but we hope that it promotes an extra level of cleanliness for these patients, these contaminated cases. We impart upon the anesthesiologist the importance of antibiotic prophylaxis adherence. And so giving antibiotics at the proper time, particularly for vancomycin. If the patient is pen allergic, it needs to be given at least 30 minutes before the skin is cut. So 30 minutes before they actually go to the operating room is preferred. And then the prepping, the sterile prepping of the patient was mandatorily provided by the nursing staff and not the physician, because we had a set group of nursing staff that worked with our head and neck surgeons, and we wanted them to do in a very standardized fashion the sterile preppage of all these patients, not have any heterogeneity to the prepping process. Redosing antibiotics, there's a prompt during surgery, a computer prompt to remind anesthesiologists to check whether it's time to redose. And then for long surgeries, I think this is pretty important, although again, this is anecdotal. Making sure that the wound does not desiccate, making sure it remains moist, because a dry wound is basically non-viable tissue, a layer of non-viable tissue sitting on top of healthy tissue underneath that can just be a culture, a petri dish for bacteria. Right? Attending always called it no beef jerky. And then we would irrigate all the surgical wounds out with 1 liter of saline at the end of the case. And post-operatively, there's been no evidence, as we all know, that prolonged courses of antibiotics in uninfected patients actually benefit them. So just 24 hours of antibiotics post-operatively. For our laryngectomy patients, any patient who had previously received radiation therapy, which was essentially every patient for us, they were always salvage cases, would receive 100 micrograms of Synthroid if they weren't already on thyroid hormone beforehand. And that, and you may find this controversial, but that was actually including patients who are new thyroid on TSH testing. Okay. So it wasn't something that we continued indefinitely. We continued for a month for these patients. It's that critical period of wound healing. And all patients were closed in a 2-layer closure. This is specifically talking about laryngectomy patients who had a partial pharyngectomy. So the standard closure either with canal suturing for the primary layer to invert mucosa, and then a second Lambert layer, which is essentially just infoaming of a second layer.
Did you get any hyperthyroid symptoms during that month?
Never did. At 100 micrograms, I'm not an endocrinologist, but we never had a problem of morbidity from the Synthroid. So, yeah. It's a relatively low dose considering most of our patients were male adults and tolerate that from a weight-based dosing perspective. So any patient who underwent a laryngectomy and had previously received radiation therapy also received a pectoralis myofascial flap, not a myocutaneous flap, but a myofascial flap. It's just an overlay over the closure that we did. It wasn't part of the pharyngotomy or pharyngectomy closure itself, but overlay as a second layer of support. And one other critical important factor, just logistically, was that the resecting surgeon was involved, not just the reconstructive surgeon, in the closure of the defect. Everyone was on the same wavelength. What's the size of this defect? What's the nature of this defect? Some of these are very complicated defects, especially as you reach up into the oropharynx. So this was a retrospective design to this study, and we basically compared pre-intervention and post-intervention outcomes for these patients. I was particularly interested in fistula, and the intervention is the implementation of this checklist. There were no major differences between the two groups. So 35 patients in the group before the checklist was implemented were compared to 19 patients after the checklist implementation. No major differences. Alcohol intake was a little different, but nothing else. Particularly radiation therapy. Preoperatively was not different between the two groups, nor was diabetes. Okay, so what did we find? So, of 11 laryngectomies that were performed prior to the checklist implementation, 8 of these experienced a fistulization event. And so, I'm not talking about fistulas. Not all fistulas are wide open necks where you have to pack and you're staring at their pharynx. But this included drainage through the Jackson-Brown drains or their cervical drains. Turbid drainage that was clearly of salivary origin. Okay. But after the checklist was implemented, we had 0. And I actually called last week to find out how many more they've done. They've done 5 more, and they've had no fistulas since. So of all patients, not just laryngectomy patients, 13 of 35 patients before surgery, before the checklist was implemented, experienced fistulas, only 2 of 19 afterwards. This is also statistically significant. And so when you look at in a multivariate regression analysis, which are the factors that were associated with reduction in fistula events, the only one that came out significant was whether they had their surgery before or after the checklist was implemented. Okay. The point of all of this is that while some of the surgical complications that we see may be related to technical skill and just the technical execution of the procedure, by and large, we postulate that you can reduce the risk of complications like orocutaneous fistula dramatically just by making sure that these simple measures, these simple preventive measures, are adhered to beforehand. None of them are that controversial, and none of them are measures that we find particularly tedious. And so implementing all of these measures in aggregate is what's important, not just one single measure. So, for example, for a diabetic patient, it's not that we just want to have good glucose control during their inpatient setting. It's also we want to make sure their thyroid function is euthyroid, and that they're getting the appropriate sterile prep in before surgery, that their antibiosis is dosed appropriately too. It's all of these things, because it's just very difficult to pinpoint for each individual patient what was the one sort of causal factor that led to their complication. Okay. So that is all. Thank you for listening to my long-winded second talk of the week. This is my fiance, and then this is us in Oregon on some beach. And
it's sunny. Surprising.
Photoshopped it.
Yeah, we don't actually get out. And this is in Carmel. This is just a beautiful day in Carmel. First time I've been there. Just soak in the water. It's even slow motion for us. Anyways, do you guys have any questions for me?
Very good.